Hello people, this is Dr. Muskaan this side, and today I'm going to discuss one very beautiful case. Let's dive deep into this case. Here is 35-year-old male who has came to ER with chief complaints of pain in abdomen and abdominal distension since 2 days. Now, thinking about the chief complaints, what all differentials will come in your mind? If I am thinking about abdominal distension, it can be gross or it can be loculated. If it is gross distension, everybody thinks about 5F. Everybody knows what are 5F. Either it can be fat, either it can be fluid, it can be flatus, it can be feces, or it can be your fetus. And if it is male, like it is in our case, so we ruled out fetus, है ना? If it is loculated distension, we think about loculated fluid, mass, hernia, organomegaly, or impacted feces. Okay. Now, the second chief complaint with which the patient came to us was pain in abdomen. Now, thinking about pain in abdomen in my mind, what first thing should come in my mind? That particular regions of abdomen and what all differentials particular region has. So how many regions are there in abdomen? 9. Very well, you are correct. Now, what are the name of the particular regions? It is right hypochondrium, then epigastrium, left hypochondrium, then your right lumbar, umbilicus, left lumbar, then it is a right iliac fossa, then it is your hypogastrium and left iliac fossa. Very nice. Now, what all differentials particular region has? If I am thinking about epigastrium, what all I can think? I can think about biliary colitis, cholangitis, cholelithiasis, cholecystitis, and your hepatitis. If I'm thinking about your epigastric region, what all things I can think? Esophagitis, gastritis, peptic ulcer, pancreatitis, and your MI. If I'm thinking about your left hypochondriac region, what main organ is there? Of course, it is spleen. So it can be splenomegaly, it can be splenic infarct, or it can be gastritis because some part of stomach is also there. Now we are thinking about right lumbar region. What all things will come in my mind when I will think about right lumbar region? It can be pyelonephritis, ureteric stones, constipation, bowel obstruction, and your colitis. And नेक्स्ट रीजन इज योर अम्बिलिकल रीजन. अम्बिलिकस के ऊपर कौन सी डिजीज होती है, उसके नीचे कौन सी डिजीज होती है? सो अम्बिलिकस के ऊपर इट कैन बी पैनक्रेटाइटिस, अर्ली अपेंडिसाइटिस एंड योर अम्बिलिकल हर्निया. एंड उसके नीचे इट कैन बी रप्चर्ड एयोर्टिक एन्यूरिज्म, कॉन्स्टिपेशन, बाउल ऑब्स्ट्रक्शन एंड कोलाइटिस. नाउ योर लेफ्ट लंबर रीजन. लेफ्ट लंबर रीजन में भी सेम pyelonephritis, ureteric stones, constipation, bowel obstruction and colitis. Now your right राइट इलियक फोसा वाला रीजन, इट कंटेन्स मतलब कौन कौन सी डिफरेंशियल्स आएंगे? अपेंडिसाइटिस, इट कैन बी एक्टोपिक प्रेगनेंसी, पीआईडी, है ना, हर्निया, ओवेरियन सिस्ट. And if I'm thinking about your hypogastric region, it contains UTI, urinary bladder, of course there can be urine retention, so urine retention and PID and testicular torsion. If I'm thinking about left iliac fossa, it contains certain differentials such as hernia, PID, ectopic pregnancy and diverticulitis. Now as a doctor, first mindset is asking the chief complaints क्यों hospital में आए हो, and the second mindset is thinking about all the differentials of particular chief complaint in your mind. Now on primary assessment, what ER team do? They do ABCS. What is ABCS? Airway, breathing, circulation and sensorium. So on airway assessment, airway was patent, there were no signs of airway obstruction. Okay, if there is no airway obstruction, of course the doctor must have checked that there are no signs of airway obstruction. So what are the signs of airway obstruction? That is dysphagia, dysphonia, stridor, choking, hoarseness of voice, patient is holding his neck and saying I'm not feeling like breathing, मतलब मेरे को सांस नहीं आ रहा. तो वो सब साइंस होते हैं एयरवे ऑब्स्ट्रक्शन. पेशेंट लेट रहे तो भी सांस नहीं आ रहा, पेशेंट चल रहे तो भी सांस नहीं आ रहा, फिर सांस लेने में दिक्कत हो रही है, दैट इज एयरवे ऑब्स्ट्रक्शन. ओके. On breathing assessment, we see respiratory rate and SpO2. Respiratory rate was 20 per minute and SpO2 was 94% on room air. So there were no signs of respiratory distress. So what are the signs of respiratory distress, my dear friends? Respiratory distress के signs क्या होते हैं? And what is respiratory distress? Respiratory distress means a condition in which breathing becomes difficult. And signs are abnormal breathing, slow or rapid breathing, unusually deep or shallow breathing, gasping for breath, wheezing or gurgling, मतलब हाई पे साउंड आ रही है सांस लेते वक्त, Skin is moist or cool. Blue skin, ठीक है, cyanotic skin, patient victim feels like shortness of breath, dizziness or lightheadedness. Patient feels like pain in chest, tingling sensations in hands, lips and feet, and fearfulness. Okay, so these are the signs of respiratory distress. Now, what are the circulation assessment? What we have seen pulse rate and blood pressure. Pulse rate was 124 per minute. That means tachycardia is there because normal lies between 60 to 100. And BP was 130 by 81. Sensorium was alert. GCS score was 15 by 15. It was E4, V5, M6. That means vocal response was oriented. Motor response, he was obeying command. And on verbal response, he was oriented, and on eye response he was opening eyes spontaneously. Okay. HOPI, patient was apparently well when he developed abdominal distension, which was insidious on onset, gradually progressive, not relieved on not associated with any relieving or aggravating factors. Patient also complains of okay, it was associated with vomiting, which was yellow in color, and it was non-projectile. So what is projectile and non-projectile vomiting? Vomiting का medical word के MSS. Projectile means it was not associated with nausea feeling. If patient is feeling that vomiting, मतलब एकदम से यहीं पर ही हो जाएगी. This is projectile. And non-projectile means patient feels nauseated. He has time to go to washroom or to near washing basin or some place to vomit it out. Okay, so what are the causes of non-projectile? सबसे simple example if you want to remember for projectile or non-projectile vomiting is, for example, you are traveling. If someone says I am feeling nauseated, please car रोक दो, and you are taking 2 minutes and then उसके बाद car रुक रही है, this is your non-projectile vomiting because patient can wait. He's or she's feeling nauseated and then he's going to vomit out. And some people are like, they are feeling nauseated, they just tell in that second and they vomit at the on the other second. So that is your projectile vomiting, that no time to go to certain place to vomit. It is just within splits of second. Okay, what are the causes of projectile vomiting? It is infantile hypertrophic pyloric stenosis, raised ICT, gastric outlet obstruction. And causes of non-projectile vomiting is heat stroke, sickness during pregnancy, GERD, esophagitis, immediate reflux as a result of food or medicine intake. So when I've asked patient that what was the color of the vomiting, he said yellow color. And how many times he had vomit? That was 2 times. Okay, so we know the type of vomiting, frequency of vomiting, and color of vomiting. Okay, past history. There's a history of road traffic accident, that is open reduction internal fixation with screws and plates was done last month. There is history of pulmonary cox in 2007. There is history of acid fluid tapping. Personal history, he's alcoholic, that is occasional drinker. He drinks only beer. He's known smoker. He passed 2-3 days back and he has decreased appetite. On examination, parallel icterus, clubbing, cyanosis, lymphadenopathy, edema, all were absent. Okay, systemic examination, CNS was oriented and conscious, CVS was S1, S2 present, respiratory examination bilateral air entry was present, and per abdomen examination shows distension and it was soft. So patient was taken to OT. 3.4 liter bile was suctioned after incision and all solid organs were visualized for any leak. After OT, patient was shifted to ICU. His prothrombin time was raised. 4 fresh frozen plasma and 2 packed red blood cells was transfused to patient in ICU. Cytic tap was done. Bilious fluid was green in color. Further, 4 cytic tap was done and it was yellow in straw in color. Investigation picture shows anemia, increase in urea, hyponatremia. Gram stain shows few plus cells, gram positive cocci in pairs and tetrad. When we have calculated SAG, that is serum acidic albumin gradient, by subtracting serum albumin from minus your acidic albumin, it comes out to be less than 1.1. Okay, so what are the differentials which should come in mind for low SAG? It can be tuberculosis, it can be nephrotic syndrome, It can be biliary ascites without cirrhosis. It can be peritoneal carcinomatosis. It can be ascites associated with bowel ischemic infarction, or it can be your, yeah, it's done, ascites which can be associated with connective tissue disease. Okay, gene expert or was done, and in that Mycobacterium tuberculosis was not detected. Okay, ascitic fluid in that total protein shows 3.2 gram per dl. That means it was transudate. Prothrombin time was 18.1. What is prothrombin time? Prothrombin time measures the clotting time of the plasma. Okay, if prothrombin time is more, it means it will take more time to clot. It means there will be more blood flow. Understanding? So prolonged prothrombin time is found in oral anticoagulant therapy, vitamin K deficiency, and liver disease in DIC, that is disseminated intravascular coagulation, renal disease, and deficiency of factors such as 1, 2, 5, 7, and 10. Troponin I plus was less than 0.01 nanogram per ml. So we can rule out cardiovascular disease. HCV, HIV 1, 2, HBS, AG was non-reactive. Ultrasound whole abdomen shows subscapular splenic hematoma, gross chronic ascites, left-sided moderate pleural effusion, left inguinal hernia, gross amount of free fluid seen in perihepatic, perisplenic, pelvic, and interlobular region with septation. CCT chest shows ground glass opacities seen involving all segments of left lower lobe and posterior segments of right lower lobe, possibly showing pulmonary contusion. Second is your mild left-sided pneumothorax, displaced fracture of 5th and 6th ribs on left side, and CCT whole abdomen shows gross ascites and abdominopelvic cavities. Management of this patient was done with injection peptase, that is piperacillin plus tazobactam, which is against both gram-positive and gram-negative bacteria. Injection metrogel, which is to prevent bacterial infection. Injection amikacin for the treatment of UTI, which is nephrotoxic. Injection Dynapar to reduce pain. Injection MCID to prevent emesis, that is post-operative nausea, vomiting. Injection Tramadol to reduce pain. Injection PCM to prevent fever. Injection Pantop to prevent GRD. Injection magnesium sulfate, which is neuroprotective agent. Injection vitamin K because prothrombin time was more. Okay, so the last diagnosis of this patient was splenic subscapular hematoma with peritoneal lavage, with gallbladder perforation, and with appendectomy. That's all. I hope you have gained some knowledge after listening to this case study. Dr. Muskaan Bansal is signing off now.